was in Amsterdam earlier this year that we had a discussion, well, with you, Margaret, Jordan, and a few others, on the concept of microelimination. So what I'm going to present is microelimination as a strategic approach on the path to the global elimination of hepatitis. I'm going to focus on hepatitis C, though there'll be some examples that can be useful for hepatitis B or indeed completely other infections and diseases. So, you know, we said earlier about premises, things are changing quickly in the field, and we've overcome the biomedical challenges to addressing hepatitis C. But that leaves us with two major, daunting public health challenges. First being access, second being coverage. We've talked about quality and safety issues of some generics, so I realize this list could go on, but thinking about how to overcome access and coverage will be the focus of my talk now as we think about elimination, and that elimination, as WHO defines it, elimination of viral hepatitis as a public health threat by 2030. So elimination is daunting. So I really do think a few years ago we thought, how are we going to entirely eliminate hepatitis C? Some people were talking about eradication. There was confusion by how we were defining elimination. Now WHO has given us a clear definition, a set of targets to monitor our progress. It's costly. We're in a session on finance. I'm glad Esteban's talked so much about prices. I won't focus so much on financing, but rather an approach that makes it a little bit more palatable, or as was mentioned yesterday, a little bit more bite-sized, whether or not it's cost-saving, cost-effective, etc. We have an increasing body of evidence about why it makes sense to reduce and eliminate restrictions on reimbursements, to eliminate all restrictions for treatment. It is a big amount of money we're talking about, and that does worry countries, however large their infected population is. It's also complex. It's increasingly becoming simplified. We're looking at models of care that can be made more and more simpler, but as I'll show, there's a number of health systems barriers to simplifying models, and we're often stuck in the pre-DAA era when we want to scale up treatment to other populations like people who inject drugs. So yesterday in the panel discussion, one of the panelists was saying, you know, we keep taking all of these bites out of the epidemic, but how do we really scale up? I think with the microelimination approach, it's about taking the right bites, being strategic in our approach in order to galvanize political support for full elimination in the population you're addressing, and I'll explain how I envision that happening. The concept of microelimination is not new, even if it's relatively new in terms of viral hepatitis. In approaching polio, we looked at elimination country by country, and eventually regions were declared as being polio-free. So you see the difference here from 1988 to 2012, and by looking at microelimination at the country level, it helps us identify where we should focus our efforts. In terms of HIV, we've had very successful programs for the prevention of mother-to-child transmission. It wasn't called microelimination, but that's really what it was. We also have a cities approach where fast-track cities are countries that have signed up to try and eliminate or end, as they say, HIV before their entire countries does. So there we have a microelimination approach focusing on urban populations. Although there's a lot of movement between cities, they have different ways or different indicators to track their progress versus the rest of their country. So it's not a new concept. In terms of hepatitis C, some of the areas where I think we could think about microelimination, and where indeed we already are addressing microelimination, would be decompensated cirrhotics. I would ask, does everyone agree on that? But the last time I did that, some people disagreed. So I won't tell you which country that was, a very advanced Northern European country that leads the world in education and health spending as a percentage of gross domestic product, felt that, well, We still had to struggle with the approval and use of DAAs. We still weren't treating all of our F3 and F4 cases. I just saw the data coming from prisons in Spain last week. Among 1,000 prisoners with hepatitis C, hundreds in the Spanish prison system with F3, F4 not being treated. And we heard a little bit about the approach towards veterans in the US and how the Veterans Authority has been able to scale up hepatitis treatment among that population. Some countries are addressing the relatively small population of hemophiliacs who are co-infected with hepatitis C, and I'll give you an example from Ireland that really changed things in that country. Transplant patients, some countries doing better than others. People who inject drugs, prisoners. There's some interesting examples recently in the north of Spain. There was a demonstration elimination project in one prison where they identified everyone with hepatitis C, provided treatment, and showed that they could eliminate in that prison. You might ask, well, what about the new prisoners? And they need to maintain that. But they wanted to show that you could provide treatment in prisons, which was very important there because it meant that prison doctors were allowed to prescribe. There was collaboration with local hospitals, and it starts to change the health system. And I see so many health systems issues as the barriers to scaling up treatment now that we have effective treatment available to us. And finally, people living with HIV, at least those who are diagnosed and in care and regularly going to hospitals and clinics for their tests and for their treatment, this is a population where everyone should be tested and immediately treated, and we don't see that happening often enough. I know in this series of symposia, you've addressed co-infection, but I really think that this is a clear, quick win. When I was at the Global Fund in certain countries like Georgia and also the Ukraine, there were pilot projects to provide treatment to people living with HIV, but very, very low numbers, 30 people, 50 people, a couple of hundred people. In other countries, it can be a deterrent to allowing treatment to be provided, but I do think addressing elimination for the co-infected with HIV population is an important next step for countries to take. I also think in terms of late presentation, presenting with F3 and F4, we need to understand how much late presentation there is in the populations and develop measures to reduce late presentation, which means eliminating treatment restrictions, and we can actually eliminate late presentation, which is important in terms of people understanding that they have hepatitis C, that it is transmissible, what prevention measures need to be taken, and how quickly can they get treated, cured for that. Now, in terms of hemophilia, let me briefly give you this example from Ireland. Is anyone from Ireland here? So you know this story well, and I hope I'll tell it accurately the way I've heard it explained to me a couple of times. In Ireland, with a relatively low number of people living with hemophilia and hepatitis C, it was decided to provide treatment to that entire population. So just a few years ago, they could announce in Ireland, it became front page news, that they've eradicated hepatitis C among hemophiliacs. Now, Ireland's a country that in 2013 responded to WHO in their first global hepatitis policy report that they had no strategy for hepatitis, for viral hepatitis. Yet at the time, they actually did have a strategy. It was quite long, and it was quite visionary, calling for the elimination of viral hepatitis by the year 2025. So it was interesting that their government focal point wasn't aware of that, since the rest of the country seemed to know about it. When they eliminated hepatitis C among the hemophilia population, the Minister of Health was so pleased at this success that it was announced on the front page of their website that not only was this a huge success for Ireland, but who was next and how would they be able to eliminate hepatitis C in the entire country. They were able to ring fence over 30 million euros immediately for treatment. They convened groups of experts that included not just hepatologists and ID doctors, but also addiction specialists and community members to really start to implement that strategy that they had, but that was pretty much in a drawer. And here you can see in the Irish Examiner, plans for hepatitis C to be eliminated in Ireland by 2026, so a little ahead of the 2030 goals, and I think that's a good thing. Let the competition start. Now, some of the advantages of microelimination, and I'm going to come with a series of questions at the end if we have time to debate and discuss, or maybe take it to the symposium next year. As you can tell, I'm quite positive about this approach, but I have been discussing with people who have been questioning, does microelimination deter from efforts for full elimination? I think it's a step along the way where you can set realistic targets and goals. It's a pragmatic approach. The time for achievement is shorter. 2026, 2030 is a long way off, but eliminating hepatitis C in 100 or 200 or 500 people in some large countries can be done rather quickly. It allows for tailored strategies, which also means you can bring in other stakeholders. So suddenly you have patient groups from hemophilia, from HIV, getting involved in the hepatitis elimination efforts because they see that it's relevant for the populations that they represent. In terms of cost, like I said at the beginning, people did very simple math. In Denmark, we said, well, with around 20,000 people with hepatitis C at 40,000 euros per treatment, this is what it would cost. Too much for us. But as you start to break it down and target your approaches, put it into years, put it along the timeline to 2030, I think the microelimination approach can bring politicians who are not willing to commit large sums of money at the beginning into addressing the elimination. You can address prevention of reinfection in a particular target group. So it allows you to think that if we go quickly into a group that's likely to transmit hepatitis C to others, rather than sort of going little by little, scaling up treatment, if we scale up quickly, we know that, we heard about this yesterday, by treating a large number quickly, it reduces the likelihood of transmission and possible reinfection in that group. And finally, microelimination projects may generate a template in a small, geographically defined population, which may be then used to model services for larger intervention programs. So as you're getting started, you can focus on a single smaller group, and you can address some of the so-called low-hanging fruit, which, like in Ireland, encouraged further public health efforts. Here's an example from a microelimination approach for people who inject drugs. If we said in country X, first we were going to address the F3 and F4 cases, no matter who they were, the question when you start to scale up treatment is, where do you go next? In Denmark, we went to what I called sort of a partial F2. Many countries will open up for F2, those with extrahepatic manifestations. But if we wanted to take the public health approach, we would want to open up to those who are also F0 and F1 and likely to transmit to others, people who inject drugs. If we're going to open up for F0 and F1 after F3 and F4, well, you really might as well open up for F2 at the same time and reduce all restrictions. This is happening across Europe, country by country. In March, Italy ended their treatment restrictions. On the 22nd of June, Spain ended their treatment restrictions. But even in countries like Portugal that haven't had treatment restrictions for a long time, they've had trouble scaling up treatment because they're not actively looking for people to test and increase the number of those who are diagnosed. So it's not just about ending those treatment restrictions, it's about having a comprehensive strategy, like I mentioned yesterday. So we do have a global strategy. We do have regional action plans for each of WHO's 6 regions. And I think it's now, Yvonne, tell me, over 80 countries that have strategies. At least in the April WHO Global Hepatitis Report, it was 43, but I think that number has already increased quite a bit. We know a number of countries have strategies that they're about to approve. Within the global health sector strategy and regional action plans, we have a series of targets. We've spoken about them, you're aware of them. What I think is important in a microelimination approach is where relevant to apply each of these targets to a particular population. So we're not looking at just elimination in the entire country by reaching these targets, but have we done so for some of the more difficult populations like people who inject drugs? Have we reached those 80% and 90% targets across the different populations? So we take an equity approach and not just an entire population approach. WHO and others have put forward the use of a cascade of care. Again, here it is globally. This is what it's divided. I don't know if I can go back on this. Yeah, here it's divided by region. This is what it looks like in the strategy. A number of different points. Different people are using the continuum of care in different ways, but typically they're doing it at the national level. I think this can be useful, again, to be done by particular populations, by fibrosis stage, so to make those estimates where you can about how many people with hemophilia are estimated to have hepatitis C, how many people living with HIV are estimated to have hepatitis C, and then look at where the fall off is along the cascade so you can target your interventions for particular populations in addition to the population in the country as a whole. And finally, I didn't mention this yesterday, but during the panel discussion, it struck me that so many of the barriers that were being put forward are linked to the health system. We've talked a lot more than I expected, about procurement issues and procurement being a barrier in some countries. In other countries, it's a financing issue, it's a service delivery issue, and how do we reach the hard-to-reach populations. It's an information issue because we're often flying blind, which isn't an excuse to not do anything, but often in terms of prevalence of the estimated population, we really have no idea what's going on, and this holds across Europe, where prevalence estimates vary so much between countries, or are simply so old, a number of countries that put forward prevalence estimates that are over 10 years old. So what I think we can do by using this WHO framework, first, the 6 actual health systems issues date back to 2007, but then as people were more into the center in WHO's 2016 health systems framework, it allowed us to take the health systems framework and develop a set of questions, and here's just a couple of examples about how to make the health system work in terms of viral hepatitis elimination. So if we just started at the top with leadership and governance, well, we'd want to know, is there a national strategy? Is there a national plan? In countries with decentralized health systems, you also need regional strategies and regional plans, like in Spain, well, we've seen it even in the US, where Medicaid reimbursement was so different from state to state. But then we want to ask, what was the stakeholder involvement in developing that strategy? That will tell us something about how effective that strategy will be, because is there ownership among the clinicians and other healthcare professionals, among the risk groups, among the patients? We'd want to know, is the workforce fit for purpose? We've already heard that we need to get testing and treatment out of hospitals. It's often solely under the domain of hepatologists or infectious disease specialists. And with all respect to those groups, we already heard the Australia examples of we need to allow testing to be done by GPs, treatment to be provided by GPs, same thing in prisons, same thing in addiction centers and harm reduction centers. So you really need to think about what it will take to have the right workforce in place. Financing, there's a lot to say about financing. It's important to be able to strategically budget and also to negotiate. We have a number of countries that still don't negotiate their prices, which is why in the north of Europe, you might be paying 4 or 5 times what we're paying for the same medicines in the south of Europe. So we've been talking a lot about the global south and low-income countries and price disparities there. But we also have that within the high-income countries, and prices in some of those countries are so high that it's become a major deterrent to taking an elimination approach. So I won't go through all of the points. Suffice it to say that by taking a health systems approach, you can make sure that all of your bases are covered. And if you adapt a microelimination approach, that might be useful in some countries that aren't able, for whatever reason, to take the full elimination approach as set out by WHO. One tool that we're developing, I call it a tool, it's really just a simple table that's adaptable, where we would take the key subgroups in a country. So this is a study we're doing in a nearby country, and since it's under review, I won't mention which. I've just changed up the numbers a little bit, but they're relatively realistic. Don't guess. But not so far away. And I can see Manal, and in a country in Europe with 35 children diagnosed, well, in terms of microelimination, let's just end that issue now by providing them treatment. But if you look through the numbers, you'll see in a number of boxes, a number of lines, it's fewer than 2,000 people are either reported or estimated to have hepatitis C. So you can start to look at, well, what will it take to eliminate in that population? What are the barriers? How do we overcome it? You can also see that even in a country with a strong health system, with strong surveillance, no data was available in several groups. In several subgroups, we only were able to find data from one particular site. But I think we had actually done this by fibrosis stage as well. And you could imagine what that looked like. All of the fibrosis stage boxes were empty. But I thought that was actually worth publishing to show we really don't know how many serious cases we have when we break it down by subpopulation. I got overruled on that, but I would encourage you to think about stratifying by fibrosis stage when you start to map out the situation, because then you can kind of go box by box and say, really, it will be easy to eliminate in this population because there's F3 and F4 cases in our prisons, and we allow for testing and treatment in prisons, et cetera, et cetera. A number of countries will likely achieve the WHO targets by or before 2030. We've already heard quite a bit about Georgia, Australia. I just throw Iceland up here. I've made it to look as big as all the other countries, but I think really this is a case of microelimination. It's a small country with a small population. We had about 1,100 hepatitis C cases, and probably by the end of 2018 or beginning of 2019, they will have eliminated in terms of the WHO definition. What's interesting, though, is to look at how the countries have done this, which populations they've been targeting, or in the case of Iceland, in terms of the globe, it's a case of microelimination where in a geographically defined area, everyone or almost everyone was identified, offered treatment, and cured. So what would I like to see on the agenda for 2018 and in the years that come? Well, it could be really nice to have a session where we reported back on microelimination successes, because you saw in some countries this only means testing or really treating 20 or 30 or 40 or a couple hundred people, and to be able to report back and say, well, in my country, this is no longer an issue for children, for most people living with HIV, for those co-infected with hemophilia, et cetera, et cetera. And now we're going to go for the next population, and this is what it's going to look like. So some of the questions, if we have any time for discussion, that I would raise, around why the microelimination approach is important, some other examples from you of successful attempts. Why do we want to focus on this, and how it can inform the larger project? And finally, these last 2 points around, do you eliminate hepatitis C first in a subset of a population that contributes to incidence increase, or do you focus on a subset of a population who's at greatest risk of mortality? and morbidity from HCV? Do we really have to make those choices? And do you have any experiences where you have had to do that, and what happened there? Thank you very much.